All right, we've got two fine gents coming up next to give us a quick presentation about monitoring patients across state lines. They're coming from Nemours Children's Health. We've got James Schnatterer, is health informatics manager and has 30 years of experience, 7 of which he spent leading the clinical applications team over there. Mark Chamberlain is also joining him, also 7 years at Nemours. Mark is a clinical apps analyst and supports Nurse Call, Alarm Middleware, Vault, and about 16 other areas of specialty. So please give them a warm welcome as they come up to the stage, Mark and James.
Thank you. Don't trip. Okay. Good morning. So I am James Schnatterer, and yes, that is me on the picture that just went away. That's how I think I still look in my head, so I wanted you to see how I feel from up here. This is Mark, and we're going to start with a brief video and then jump into our presentation. So sit back and enjoy. The mission of Nemours Health System is to restore and improve the health of children, regardless of their ability to pay. We have close to 400 beds on 2 hospital campuses, one in the Northeast and one here in Orlando.
The Clinical Logistics Center is intended to provide an enhanced oversight and electronic monitoring for now 2 hospitals that Nemours runs. It recognizes the fact that nurses, as conscientious as they are, cannot be in all places at all times.
The Vault platform is integrated with our Philips patient monitoring system, our nurse call system throughout the hospital, and our clinical logistic medics use our middleware for sending urgent notifications.
So we made a decision to purchase the Zebra TC51 mobile device because it is a hospital-grade device that is very durable, very easy to clean, and has more capabilities than the previous device we had used.
In clinical logistics, we monitor every patient that's on the cardiac monitor. So we look at their rhythms, their heart rates, their O2 sats, as well as their vital signs. And if they trigger any infections, we look at that as well.
So the biggest benefit for the Clinical Logistics Center is that we can bring much more timely and effective care to a patient at the time and place that they need it. All of that clinical data is now able to identify patients at risk far earlier than we used to be able to do so. And not only detect risk, but tell somebody about it.
Vault has helped improve communication by improving our patient care and facilitating communication through all areas of the hospital.
Vault has helped us with communication with the nurses, not only looking them up easily, but we could tell when its message has been delivered and read. So we know if they haven't read it yet, we need to move up the ladder to someone nearby or a charge nurse.
The primary benefit of the Vault Zebra partnership, in combination with the Clinical Logistics Center, is to allow the patient's clinical care team to work together seamlessly throughout the day, regardless of where they are at the moment. There's no more need to be geographically in the same place to work together as a team and have the best information available to make the best decisions for the benefit of the patient.
Okay, so now we're going to tell you a little bit about how we do that. And before we do, if you don't mind, I have to do a little infomercial for Nemours so you know who we are. So Nemours was founded in 1936 through the Testamentary Trust of Alfred I. DuPont. And our original hospital, the Alfred I. DuPont Hospital for Children, was built on the grounds of Mr. DuPont's estate, a mansion similar to where I'm sure we're going tonight. But the Nemours, now we are, and when we saw our first patients in 1940, we were orthopedic pediatric patients only, and we've come a long way since then. So if you look here, the Alfred I. DuPont Hospital for Children, as we're known, is in Wilmington, Delaware, and the Nemours Hospital for Children is in Orlando, Florida. So we have 1.7 million annual encounters, and our prevention and population health is impacting more than 1 million children in 23 states. And our Center for Children's Health Media has 250 million site visits annually. We employ about 8,000 associates, and as you can see, we're across the entire Delaware Valley and the state of Florida, and expanding into Georgia as well. So all of this makes Nemours one of the nation's leading pediatric health systems. We have 410,000 unique patients each year, and we collaborate with 19 different hospitals. So we're leading the way to help children grow up healthy using a holistic and multifaceted approach to reach children and families where they live, work, and play. The picture on the upper right-hand corner is the Alfred I. DuPont Hospital for Children, as I mentioned, on his estate. And then the picture below is the Nemours Children's Hospital in Florida. And that is not a Photoshop picture. Each of the room light displays are the children pick the color that they want their room to display from the outside. So it gives like the room has a glow inside, but you know, it's, as you can see, the kids have a lot of fun with that. So we just, these are some of the awards that we have won and recognition we received over the years. In 2010, we joined the Leapfrog Group, which is an initiative to spark breakthrough improvements in safety, quality, and affordability of healthcare. In 2012, we started reporting to the Leapfrog Group. There's 1,300 hospitals that report, so we're in the 95th percentile. And 2 years after Nemours Children's Hospital opened in Orlando, they were in the top 10. So with that, many of you may already know Mark. He is a permanent fixture at this conference every year. And he is the primary reason that we are standing here, because he has built most of what you're about to see. And he's going to tell you everything that I know you want to hear now that my infomercial's done. So, Mark, take it away.
Thank you. All right, thank you, James. Okay, so this is the Clinical Logistics Center at Nemours Children's Hospital in Orlando, Florida. The medics you see here are the second set of eyes and ears for nursing. So the medics, the paramedics at this logistics center in Orlando monitor all the patients at Nemours Children's Hospital in Orlando, as well as Nemours Alfred I. DuPont Hospital for Children in Wilmington. They can monitor up to 400 patients. They monitor those patients around the clock, and of course, if any of those patients display any signs of difficulty, they can initiate codes and staff response to help that patient immediately. They also have access to a high-definition camera in each of the patient's rooms, and we will get into more of that a little bit later. So, as I said, the logistics center is staffed by certified paramedics. They work 10 to 16-hour shifts with a break every 4 hours. They work at 5 workstations, 3 of those workstations directed to monitoring patients at AIDHC, and 2 of those workstations directed at NCH. So at this time, those workstations are permanent. We really haven't set them up to be redirected on the fly, so to speak. And then you see here a list of the applications they have up at those workstations for their shift. Volt Messenger, which is how they communicate with the staff regularly. They have a Volt 1 device at the workstation for alarm escalation. They have Epic, which is our EMR. Their email, Spoke Messenger, which is our middleware. TalkGuard, our patient tracking system. Responder 5, which is our nurse call system. And ICU Monitor, which calculates patient scores that generates their protocols. So these are the most impactful responsibilities that they have. Of course, the physiological monitoring, the protocol-driven responses. They are part of the alarm escalation. And They monitor and respond to the clinical surveys, clinical rules surveyed by Epic Monitor, such as CLABSI, CAUTI, neonatal sepsis, and PEWS. So here's a diagram of the integration we use to get our alarms to the Volt device. Whether it's a red alarm from the bedside monitor, a ventilator alarm, or a nurse call alarm, that's all sent to our middleware, which of course contains the assignments for the appropriate nurse or care team member to receive the message. From there, Spoke sends to Volt directly to the Volt device that that nurse or care team member is carrying. And this will tie in with the logistics center as they are the last tier in our escalation. Okay, so I'm not sure what the rule is for the amount of information that you're allowed to have on a slide, but I'm pretty sure this is pushing it. But basically, this is on the right there. You see our input systems: patient monitoring, nurse call, the web client for making the assignments. The middle area is the integration layer, which is our Spoke messenger, processing all those messages, and then the outputs: WCTP to Volt, SMS to cell phones, and SMTP to email. So this is our Philips patient monitoring presence in the logistics center. Leadership at Nemours Children's in Orlando opted not to have monitoring at the nurses' stations on the med-surg units, and the HEMONC unit. So what we have in there are the actual central stations for that monitoring. And then at those two workstations, there's 32 sectors at each station, providing 64 unlocked sectors. And this allows them to better manage monitoring those patients. They can switch to monitoring between each other. They can stop and start monitoring as needed of any patient in the hospital. So at AIDHC, they opted to have their central stations, of course, on the unit. So what we have in here on the wall are the overview stations, which are basically just mirroring the view of the central stations up there. And at their 3 workstations, that provides for the 96 unlocked sectors for them to maneuver patients how they see fit. And there is we use a 1 gig circuit for that traffic between Orlando and Delaware, and we have backup routing options through a major networking hub of ours in Jacksonville. So both hospitals, we only send specific red alarms to Volt, and that's of course to better manage alarm fatigue. Our middleware provides an escalation process so that the nurses have the ability to immediately escalate an alarm if they are unavailable, or if the alarm is not responded to, it just lets the escalation process take over. And charge nurses and the logistics medics are in the last tier of escalation, and the medics' response is to reach out to that primary nurse using Volt Messenger, and if they don't receive a response, they go ahead and call that nurse's Volt. So here is an example of a protocol for the medics. This is a decision tree that determines their response for a pulse ox alarm. They have many other decision trees, including for CLABSI, CAUTI, sepsis, shock response, and or prevention, and PEWS response. So at both hospitals, we use the Responder 5 nurse call system. Of course, we've got hundreds of devices installed at both sites. In the logistics center at each workstation is a Responder console phone. That's pictured there in the lower right. This will display the type of event that's been initiated as well as the location, and it provides the medics the ability to communicate into the room. The connection there is to the head wall unit and pillow speaker, and that communication is also available for all of our patients in Wilmington. We use a Rollin-provided remote network concentrator. It takes the local layer 2 traffic on the nurse call system, converts it to layer 3 for our network, and delivers the traffic. So the medics are part of primary notification for urgent events as well. They have the ability to audio and video into the room to assist with responses such as monitoring chest compressions and just being available to reach out to any other units, providers, or clinicians that are needed for that event. So, a little dive into an integration we use with Volt and Nurse Call is giving the nurses the ability to call into directly into the patient room when they receive the alert. So we do that with the integration of Responder 5, Spoke, Volt platform, and our Cisco Call Manager. As you see, this is the alert they receive. They have the 3 options of accept, reject, accept, and call. Accept takes ownership of the alarm and ends the escalation. Reject will let the escalation process take over. And accept and call will stop the escalation process as well as initiate a call back into the room, from Volt to our Cisco Call Manager onto Rollin and eventually into the patient's room. All right, so here's a diagram of that integration. So in a little more detail, as I said, the call is initiated from Nurse Call. So the alert is sent to Volt. The nurse then selects accept and call, which initiates this call including a dial pattern to reach the room. So the dial pattern is received from Volt to our Cisco Call Manager. The dial pattern includes a prefix, which tells Cisco to go ahead and route this call to our Rollin Berkecki SIP server. Then it chops that prefix off, sending only the extension needed for Rollin to connect the call to that room. So when Rollin receives that call, pushes it on through, connects to the patient stationed at the head wall, and usually that's where the pillow speaker is plugged in. So the conversation takes place at both places. Pillow speaker could be under a pillow or a blanket or something like that. So from the nurse's end, on the Volt, it's just a regular phone conversation. However, in the room, it's an intercom conversation, so the nurse can speak with the patient and family at the same time. So, as I said, Spoke Messenger is our middleware, and of course processes our patient monitoring alarms, our nurse call alarms. In Orlando, for NCH, our medics actually use the Messenger client to send codes, census notifications and updates, equipment outages if the MRI or CT is down, and the notification of an inspector arriving on site. They can send that directly to Volt. These are manual messages sent to various groups in Spoke. And these groups, for now, are static. It's some of an umbrella approach. They aren't managed in between shifts. And some good news, when we upgraded to Volt platform, we were able to do away with what we called a Volt blast group. It was kind of catch-all for everyone that uses Volt. And this was a very large group in our middleware that had to be managed. So now with platform, we can send an announcement and it immediately gets out. It's a lot easier and quicker. It gets out to everyone online at the time. Okay, so I wanted to share a little bit about a continuous improvement project we're wrapping up at NCH. And it's around, well, it was really focused on patient flow. So they wanted to focus on discharge planning at admission, communication across the care team members, and coordination of the room turnover process. So what we did was we created 4 buttons on our the Rollin staff terminal there. You see at the top, we've got one of those in each of the patient rooms. We created 4 buttons, room dirty, cleaning in progress, room clean, and room ready. So these 4 buttons capture that room turnover process and everyone included. So room dirty is pressed when the patient care tech on the floor escorts the family on out, letting EVS know that the room is available to be cleaned, as well as the medics know that this turnover process has begun. So cleaning in progress is pressed when the EVS tech arrives, and this alerts the EVS management that cleaning is now started. Also, we have an integration with our EMR, and these steps update that bed status as they move through the process. So next is room clean. So the EVS tech will press that when they're done. This will go to local patient care tech for them to come in and put the finishing touches on the room so it's really ready for the next patient. We had to work through that a little bit because we discovered that room clean does not mean room ready. So we had to develop a really ready state. So they come in, put the final touches, then they press that room ready, which notifies the local charge nurse, our house supervisor, and the medics in the logistics center that that room is now ready for the next patient. Obviously a manual process, so we had to develop rules like we worked with Rollin to have the next button in the process, cancel the previous button in the process, so it kind of mitigated any issues there. And unfortunately, I don't have any metrics. We just went live not too long ago, but I'm sure they are eager to find how that's really helped our room turnover process. So, all right. So now I'm going to turn it back over to James to talk about integrating data from the EHR.
Thank you, Mark. Nice job. So we do use Epic as our electronic medical record, and we refer to that as Epic Nemours One. Epic allows for, thought Mark had the screen up. So Epic allows for seamless integration of our primary care, urgent care, subspecialty care, and hospital interactions because our EHR is one database for the entire enterprise. The Clinical Logistics Center, as Mark mentioned, uses data from our EHR to provide 24/7 care for our inpatients at both campuses. So this is Epic Monitor. So I'll let you kind of look at that a little bit. It displays in table format alerts designed to detect real-time specific patient characteristics within the EMR to the paramedics. So, for example, the combination of fever and an elevated white blood cell count in a patient with a central venous catheter alerts the paramedic to search the EMR for specific antibiotics to avoid central line-associated bloodstream infections. The pediatric early warning scores, or PEWs, entered by the nurse are also electronically tracked to ensure proper escalation and monitoring of potentially higher level of care if needed. So this predictive analytics tool helps prevent hospital-acquired infections such as CLABSI and CAUTI, as Mark had mentioned. So Mark talked about the audiovisual. So I know there's 2 screens here, so I'm not going to use the pointer, but that's our high-definition camera. This is an actual room. All of our patient rooms are private rooms. So it's an HD camera, and the camera has the ability to zoom in, and you can view the rise and fall of the patient's chest. So it's a high-quality, high-definition camera with an audio connection through Responder 5, as Mark mentioned. So the medics can confirm with direct visual confirmation through bedside cameras and distinguish real alarms from nuisance false alarms. So this does help the bedside caregivers and facilitates the Clinical Logistics Center support of the bedside staff during acute clinical crisis or resuscitation. So they're an extra set of eyes and ears. They can be documenting for those providing the care in the room real time. So talking about the alarms, I'm going to dive into that a little bit. So I think this is a one-day sample. So we had 1,137 total physiological alarms. 21% of those alarms were false alarms. Of those, of the real alarms, 18%, there were action taken by the paramedics for 18% of those alarms. And 72% of those, of the action taken were either audio or audio-visual communications. So I did want to mention that alarm fatigue, or those false alarms, was identified as the primary cause for 80 hospital deaths reported to the Joint Commission from 2009 to 2012. So to dive into that a little more, these are the types of alarms that did lead to audiovisual communication. So of those 115 that the medics took action on, there were 26 texts to providers via VoltMe. There were 17 phone calls to nurses via Volt1, and 2 actually required a rapid team activation. So now there's a lot going on this screen. So on the left-hand side there are types of alarms. So low SpO2, high heart rate. The second column is the initial action taken by the paramedic. So basically there's an alarm that goes off. They are communicating with either the provider or the patient, and then the action that resulted was increased IV, higher SpO2. I'm sorry. Oh, hit the wrong button there. So I just wanted you to I didn't want to read the whole slide to you, but give you an idea of what types of actions were taken by the paramedics. Okay. So we do have some success stories. The medics have caught seizures when no one was in the room, because 24/7 they are monitoring the patients. The nurses do have to walk out of the room. CLABSI protocols have triggered early intervention, and patients have been sent for a surgical procedure with no delay. 0 delays to get the patient the help they need exactly when they need it is really the number one goal of our Clinical Logistics Center, and that is what we have seen happen time after time. So, believe it or not, we use the Volt platform throughout this whole process. We're now over 800 devices, and we have 550 VoltMe apps on physician personal smartphones. So in total, this is a breakdown of our 2 hospitals, the totals that we have. And some of the volumes that we're seeing, we've done about 5 million secure texts between January and August of this year alone, and over 400,000 phone calls in that same period. So we made a decision earlier this year to go from a customer-grade smartphone to the Zebra TC51 hospital-grade device, and we don't really call it a smartphone anymore. It's like a handheld computer. It can do a lot more than your typical consumer device. So the staff absolutely love it because it's very durable. And I firsthand, when we were deploying these up at the hospital, I was carrying 4 or 5 of them at a time, and I was walking, and I did drop a phone. It did bounce, as they said it would, and I picked it right up, and there was no issue. So we support these devices, and and I wish I had put a slide in here about the number of tickets that we were getting on a daily basis for broken devices, and that number has plummeted because these are very durable. The other number one thing that they like is we have 12-hour shifts, 7A, 7P, 7P to 7A. The device holds its charge for that entire 12-hour shift. So they hand it off to the next person, switch the battery, and then it lasts for the next shift. They also love it because it's hospital grade, durable, and they can use any of their cleaners up on the floor to sanitize these devices without worry of harming the device in any way. So they feel like they have a more secure more durable. They're not afraid to drop it, which they still do, and they're not afraid that they're going to hurt it when they clean it. So I did want to share a couple of quotes from people who, Derek, one of our PICU charge nurses, said, you know, it's gotten to the point now where he wouldn't feel comfortable walking away to another room if he didn't have his Volt phone with him. Having peace of mind that Volt will instantly notify me of any critical alarms is comforting and alleviates anxiety. And Dr. Torres is our chief of NICU here at the Children's Hospital in Orlando, said Volt allows us to take inefficiencies of communicating out of the equation. So the Clinical Logistics Center has been it's been a game changer for our health system. We continue to grow. We're about to open 30 beds, increase our SICU to 30 beds on the 6th floor at the hospital here. We just opened a new NICU at our hospital in Delaware, expanding that as well. So we're in the process of building a second clinical logistics center on the campus in Delaware, and then the backup will be the clinical logistics center in Orlando and vice versa. So we'll have on-site clinical logistics centers for both campuses, and then there'll be backups for both. We've had a number, so whenever HIMSS is in Orlando, poor Mark is just doing tours pretty much 24/7 of our clinical logistics center. We have people visiting from all over the world to see it. You know, from what we understand, and we've been told that we were the first in the world to have a clinical logistics center, and now it is taking over. And at that point, we'd like to turn it over for questions.
Or is it lunchtime?
Nailed it.
I like it.
Great job, guys. I'm going to be helping them out with the moderation of this quick Q&A session before we break for lunch. So, yeah, who has any questions? I will say, real quick reminder, if you have a question, just raise your hand. Either Kendall or Daniel will come find you, and just identify yourself. We're all friends here as well.
All right, Mark, right over here. First question for you. You say that they're all private rooms. Is there and there's 24-hour monitoring, but is there a doorbell or any audio-visual handshake that occurs prior to dropping in on this private room?
Yeah, so they do start with the audio to let everyone know in the room that they are going to begin videoing. So the around-the-clock monitoring, of course, is through the Epic record and Epic Pew scores and other scores that are tallied in Epic. And then if they do need visual, they will audio first to get confirmation on that. Unless it's you know, an urgent matter and no one's responding, they'll jump right in there.
Jump right in.
Yeah.
And so, Jeffrey, for you, you mentioned working with Rollin Responder 5 on configuration. Were you actually able to work directly with them? Because they seem to be like the wizard behind the curtain. You have to go through.
So we're spoiled, and I don't know. I know we've got a group out here from San Francisco. I'm not sure if they're on Responder 5 or not, but there are actual 2 franchisees of Rollin, which I guess was recently purchased by Amatec. So we do deal with specific Rollin engineers, and that's unfortunately, like I said, for Florida and California only. So it is a much different task in Delaware. I will say that, so I understand where your question's coming from.
And Mark is a much bigger, more intimidating person than I am, so he does get a much quicker response than I. No, just kidding.
All right, Hannah.
How do you guys keep track of the equipment and batteries and all that?
Well, that's a great question, and it works best on units that have unit clerks. Surprising. So that's a great question. I think everyone struggles with that. We try to enforce the sign-out process for the phones.
We do have a branch in our IS department that is working on an app to track the devices.
Yes, that's where I was going. So close.
But
close.
as of right now, we do if we do occasionally have devices disappear. Now we have found with this mobile device, it's not as attractive to disappear as the previous smartphone because once it walks off site, it's useless pretty much. So that has helped.
And to be honest, the batteries can walk. I think that's okay because you're We haven't had batteries leaving a unit and then them falling short yet. We've been live for a couple months in Orlando. So it appears if we've got Volt users that are all over the hospital, if they, for some reason, didn't charge a phone from, or the battery from the day before, they'll stop by a unit and take a battery, but they'll also leave theirs to charge. So.
Hi, Mark.
Hey.
A couple of questions. So first, it's really interesting that you still retain that human component in your clinical logistics center where you have these monitor watchers or paramedics. I have a people question, not a technology question, is in being a technology person, I wonder what is the relationship like between that paramedic and nursing? Like does the floor nurse hate it, or do they have a good relationship where she's like, we've got this? Then the second question is the nurse call integration with the callback feature through Rowland. I think when we proposed integrating nurse call through our middleware in Volt, the first thing our nurses said was we don't want patient calls because there's such a large number of those. I get it, it's about that customer experience, but I think the dread was that they were going to be inundated with patient calls directly to their Volt phone. So how did you navigate that buy-in from nursing? So sorry, two questions there, but.
I'll answer the second one first. To be blunt, it really wasn't their choice. Nursing leadership decided that there's too many times that the unit clerk with all of their responsibilities are not going to be at the nurses station. So with unmanned nurses stations, they wanted that nurse call to continue to go to the nurses' Volts. So that was the answer there. For number one, it was much easier in Orlando than in Wilmington because we opened with the logistics center when we opened the hospital in 2012. So it was a relationship, from day one. Wilmington was a little bit of a different story. Those nurses had been caring for their patients for years prior to any assistance from a paramedic. So it did take some getting used to. Some of the protocols and required responses were, reviewed, changed, kind of reduced, I think, the medic's involvement with the patient care up in Wilmington. But it's been, I think they found a happy medium there, and it's been working well. But yes, there was a hurdle there, that relationship.
Great questions. We've got time for a couple more.
You were talking about the bedside monitoring, and you said there was no local monitoring at a couple of the sites. When you say no local monitoring, there's nobody monitoring the central station, or there are no central stations?
There are no central stations on the med-surg units as well as our HEMONC unit. They do have the monitoring in the ICU areas.
So in those med-surg units, if a clinical person wants to see something or look at it themselves, do you have a process for that?
No, they would have to. They'd have to go in the room.
Okay.
Yep. Yeah, they would. They decided not to have any central stations up there, which was interesting. Go ahead. Recordings of would we record?
Can you just
that in Epic
repeat the
Monitor?
question?
Oh, sorry.
I think the question was recordings of the video. So we video into the room with Epic Monitor, and then it does become part of the chart.
Okay.
So.
Interesting. That's next year's presentation.
Yes. Yeah.
It's an optional integration. You have a number of cameras to pick from, but I'm not that familiar with Epic. I know that there is part of the patient record you could go to, and it does display that video. I can find out.
Yep.
I can catch up with you later today or tomorrow, and I can get the details. Okay. 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 I can follow up on that for you.
We'll get the storage question for you. And did you have?
Was asking what Video is that the video solution they use within Epic Monitor from the camera?
What was that?
Is Video the solution?
Oh, I don't know.
I'm not sure. Well, we can find out for you.
Yeah, I have a question. I love this approach. It, it reminds me of NASA and mission control, having kind of the paramedics on site looking at all the clinical data and then parsing out the information appropriately. And from a clinical standpoint, it seems just common sense the right thing to do. My question has to do with the economics of it. So I imagine there must be a lot of upfront expense, both in terms of physical plant with the devices and the space, as well as personnel with the paramedics. Is there a return on investment outside of the clinical aspect of it, or is this just a mission-based cost that the organization assumes to deliver better clinical care?
So it was a mission-based. Dr. Stephen Lawless is who had this vision. When we knew we were going to build this hospital, they wanted to open with the Clinical Logistics Center and then bring it to the other hospital in the north. I don't have that data, but there is a slide that he prepared for us, and I wasn't comfortable speaking to the savings, but there is a calculation that shows we're saving about $6 per hospital day because of all of the false alarms that aren't making their way to the actual nurses. So when you take the nurses' hourly rate times the number of patients, and so it was a very complicated calculation, but it did lower the margin by $6 per hospital day. But I can send you the specifics of that calculation if anyone else needs it.
All right, James, Mark, thank you guys for a really awesome presentation. Thank you.